Hello, good afternoon to everybody. You are welcome to this webinar organized by Interasthma, Global Asthma Association. Today we cover a really hot topic because we are in the era of biologics. We have great interest in this kind of approach, but obviously is an ongoing research. We need always to clarify the diagnostic criteria, but the criteria for the beginning of this kind of therapy, but also the criteria to evaluate the efficacy of a biologic in asthma. So today we will have the presentation of data coming from a worldwide survey performed by the staff of Interasthma with the collaboration of people coming from really different part of the world. All the participants to this survey were colleagues involved in severe asthma treatment. I'm proud to introduce Angelica Tiotiu. Angelica is a physician of the Department of Pulmonology of the University of Lorraine in France, and she has led this kind of research. She will present us our belief perception about the criteria that we need to evaluate the biologics and the efficacy of the biologic, the effectiveness of biologic in asthma. Please, Angelica.
Thank you very much, Fulvio, for the introduction. I would like to do some wishes for all the people that are online and are watching us. Best wishes for this new year and for all my friends and colleagues and their families. I'm Angelica Tiotiu. I'm a chest physician in the University Hospital from Nancy. We talk today about criteria to evaluate the efficacy of biologics in asthma. You can see my screen.
Yes, Angelica, we can see.
Okay, very well. The results from a Global Asthma Association survey. Please find here my disclosures. I was investigator for several clinical trials. I'm also a member of expert boards in the Novartis and the Sanofi, and I have a lot of communication for AstraZeneca, Boehringer, Chiesi, Novartis, and Takeda. In the summary, after a short background, I will talk about our objective, the method, the results. I will discuss the results before to conclude. I can move on. Yes. As you know, different agents could induce epithelial injury. The allergens will be presented to dendritic cells that will induce T2 cell differentiation and activated B cells to produce IgE specific for allergens. We have also microbes and pollutants that could induce epithelial injuries and the release of alarmins like IL-33, IL-25, and TSLP that will activate the innate lymphoid cells to produce IL-5 cytokine that will activate the eosinophils and induce eosinophilic inflammation in asthma, and also the anti-IL-13 that will activate the goblet cells to produce mucus. We have now several biological therapies that are available to treat this inflammation in asthma, and you know very well the anti-IgE antibody omalizumab that will block the IgE specific for allergens. We have also the antibodies for the anti-IL-5, mepolizumab and rezlizumab, and for anti-IL-5 receptor, beralizumab, that will block the eosinophilic activation. And more recently, the anti-TSLP antibody, tezepelumab, was approved also for the severe asthma. And this antibody will block the TSLP unalarming. As you know, GINA guidelines summarize the current antibody and with their indication and with their indication. For anti-IgE, the omalizumab could be administered in children and adults with 6 years old severe allergic asthma, but the omalizumab could be also administered in the nasal polyposis and chronic spontaneous urticaria. For the anti-IL-5, the mepolizumab could be administered by subcutaneous for children and adults with 6 years old in severe eosinophilic asthma, but also in the eosinophilic granulomatosis with polyangiitis, nasal polyposis, and hypereosinophilic syndrome. Rezlizumab, also an anti-IL-5 antibody, could be administered intravenous in adults with severe asthma, and the beralizumab, an anti-IL-5 receptor antibody, could be administered subcutaneous in people with severe asthma and 12 years old. Dupilumab, an anti-IL-4 receptor antibody, could be administered in people with more than 6 years old, subcutaneous, and these people need to have a severe eosinophilic asthma with markers of type 2 inflammation or maintenance oral corticosteroids, and other indications are moderate severe atopic dermatitis and nasal polyposis. More recently, the anti-TSLP antibody, tezepelumab, was approved for people with severe asthma and 12 years and more than 12 years old. As you know, the GINA guideline established very well-defined criteria for the eligibility for different biological therapies, and also several predictor factors were identified. For the anti-IgE, the omalizumab, it should be administered in severe allergic asthma, and the people should be sensitized on skin prick test or have specific IgE antibody, and we calculate the dose according to the total serum IgE level and weight. And these people should prove exacerbation in the last year. As predictors for a good response to anti-IgE in asthma were found a blood eosinophil count superior or equal to 260 cells per microliter, an EFINO superior or equal to 20 ppb, allergen-derived symptoms, and childhood onset asthma. For the anti-IL-5 receptor antibodies, the patient should have a severe eosinophilic asthma with blood eosinophil count superior or equal to 150 cells per microliter for the mepolizumab, or 300 cells per microliter for beralizumab, and with exacerbations in the last year. as predictors for a good response to anti-EL5 or anti-EL5 receptors were found the higher blood eosinophils, more exacerbations in previous year, adult onset asthma, and nasal polyposis. For the anti-EL5 receptor antibody, it could be administered in severe eosinophilic asthma with exacerbations in last year, blood eosinophils superior or equal to 150 cells per microliter and inferior or equal to 1,500 cells per microliter, or if you know, superior or equal to 25 ppb, or taking maintenance oral corticosteroids. As predictor factors for a good response were found higher blood eosinophils and higher FeNO. For the anti-TSLP antibody, the eligible patients are those with severe asthma and exacerbation in the last year, and as predictors for a good response were found higher blood eosinophils count and higher FeNO. The GINA guideline recommend to evaluate the response at 4 months after starting them and assess the response. But currently, there are no well-defined criteria for a good response, and current guidelines suggest to consider exacerbations, symptom control, lung function, side effects, treatment intensity, including oral corticosteroids dose, and patient satisfaction. In the literature, we can find different criteria to evaluate the efficacy of biologics in asthma, several including minimal clinically important difference, defined differently in the studies, such as at least 50% reduction in exacerbation rate, reduced by at least half of daily systemic corticosteroid dose, the improvement of EPV1 by 200 milliliter, the increase of ACT score by at least 3 points, or of the ACQ score by at least 0.5, or the achievement of an ACQ score inferior to 1.5. So you can see here the heterogeneity of the criteria proposed for the evaluation of the efficacy of biologics in asthma. Several studies used also more complex criteria, such as a standardized measure to assist response to therapy, SMART, including 3 modules. The first one defined the responders according the physician's opinions, and the responders are the patients with complete control or marked improvement, and non-responders, the patients with limited or no improvement or worsening of control. The second module includes 6 clinical parameters: the reduction by at least half in number of asthma exacerbations, the reduction by at least half in number of systemic steroid treatment, the reduction by at least half in number of emergency or unscheduled healthcare visits, reduction by at least half in number of hospitalization for asthma, the improvement in mean EPV1 by at least 12% and 200 milliliter, the improvement in mean ACT score by at least 3 points. The responders for this module were defined as patients with at least 3 of 6 positive response parameters And the non-responders, the patients with less 3 of 6 positive response parameters. And the third module defined responders by both M1 and M2. You can see that that this criteria is difficult to apply in practice. We can also find in the literature the notion of super responder, and by Delphi method, it were established several criteria: major criteria, exacerbation elimination, major improvement in asthma control, cessation of maintenance of oral steroids, and for minor criteria, decrease of asthma exacerbations by 75%, well-controlled asthma, and improvement in FEV1 by more or equal 500 milliliters. For a super responder, the improvement should involve 3 or more criteria, at least 2 of which should be major criteria and should be assessed over 12 months. When we know that in practice, we have several super responders, but not all patients are super responders, unfortunately. So our objective was to establish consensus criteria to use in practice for the initial evaluation of response to biologics after 4 months of treatment. And we started to look the usual criteria for the evaluation of a treatment in asthma that involved usually the symptom control, the exacerbation, the side effects, and the lung function. And we applied Delphi method. I was the facilitator, and the first step was to create a panel of experts in asthma, and our panel includes 13 members, 7 pulmonologists, 4 allergologists, 1 internal medicine specialist, and 1 pediatrician. The selection was done on the basis on their clinical expertise, prior published research, expert recommendations, and membership in global asthma. After this step, we create the questionnaire with 10 items, including a question for the asthma control, exacerbation, lung function improvement, daily oral corticosteroids use, and side effects. And as you can see, the first question was to improve the ACQ score by 0.5 points, or the ACT score by 3 points. The second question, to obtain an ACQ score inferior to 1.5, or an ACT score superior or equal to 20 points. The third question, to decrease the number of asthma exacerbations requiring systemic corticosteroids by half. Fourth question, to have no asthma exacerbation requiring systemic corticosteroids. The fifth question, to improve the FEV1 by 10%. We put this question because the cutoff of 10% was previously described as associated with an improvement in the perception of symptoms, dyspnea by patients. The sixth question, to improve the FEV1 by 12% and 200 milliliter. Seventh question, to reduce daily oral corticosteroid dose by half. 8, to achieve complete withdrawal of daily oral corticosteroids. 9, to have no side effects. And 10, to have minimal side effects. For each item, 5 answers were possible. A, no importance. B, low importance. C, moderate importance. D, high importance. and A, very high importance. And this questionnaire was validated by all the members of the expert panel. Before sharing it on the INES platform, Inter-Asthma Scientific Network, by mass mail to Global Asthma Association members, contact list of the co-authors, National Association for Specialists, and social media between the 1st July and 31st August 22. We done the analysis for each item of questionnaire, a descriptive analysis according to the answers, but also a scoring of the answers. A, 2 points, B, 4 points, C, 6 points, D, 8 points, and A, 10 points, in order to compare the similar items concerning the same objective, such as symptom control or exacerbation or daily oral corticosteroid use reduction. As predefined conditions, we choose to select our criteria by a median score superior or equal to 7 and more than 60% of responses high importance and very high importance. All selected criteria were validated by the 13 experts. As results, we obtained 132 questionnaires completed by specialists in asthma across the world from 31 countries. Most of half of them were pulmonologists, 1/3 of them allergologists, but we have also internal medicine specialists, pediatricians, and public health specialists. The predominant gender in the survey was male, and you can see then most of people that participated to the survey was physician with experience in asthma, because 35% had age between 50 to 60 years old, and 28% between 40 to 50 years old. According to the distribution per country, we can see then in France we have more participants, followed by Greece, Argentina, Italy, and Mexico. As results for the improvement of the ACQ score, the question 1 to improve the ACQ score by 0.5 points, or the ACT score by 3 points, and the second question to obtain an ACQ score inferior to 1.5 or an ACT score superior or equal to 20 points. We can see that the median was equal, but a significant difference was found for the means, because for the second question, the mean was 7.8, and for the first one, 7.1. When we look also the distribution of the answers, we can see that more participants accorded high importance and very high importance for the second question, to obtain an ACQ score inferior to 1.5 or an ACT score superior or equal to 20 points. Concerning the question 3 and 4, to decrease the number of asthma exacerbations requiring systemic corticosteroid by half, and to have no asthma exacerbation requiring systemic corticosteroids, we can see that the median for the second question was higher, but not significantly higher. And when you look the distribution of the answers, we can see that most of people considered as very important to have no asthma exacerbation requiring systemic corticosteroids after 4 months of treatment by biological therapy. The question 5 and 6 concern the lung function, and we can see that we found a similar median without a significant difference between the scores. And when we looked at the distribution of the answers, we can see that most people found these items as moderate important. For the question to reduce daily oral corticosteroids dose by half and to achieve complete withdrawal of daily oral corticosteroids use, we can see that the median and the mean score was significantly higher for the second question to achieve complete withdrawal of daily oral corticosteroids. And when we look at the distribution, we can see that most people accorded very high importance for this item. And finally, for the side effects, we can see that the median was similar and also the mean value was comparable, and most of people consider it as high important and very high important to have no side effects or to have minimal side effects. When you look the ranking of the items according to the answer very high importance, we can see that only one question was superior to our cutoff, 60%. And this question was to achieve complete withdrawal of daily oral corticosteroids use with 67% of answers, followed by to have no asthma exacerbation requiring systemic corticosteroids, 57%, to reduce daily oral corticosteroids dose by half, 46%, to decrease the number of asthma exacerbations requiring systemic corticosteroids by half, 45%, and to have no side effects, 37%. Now we can see here the top 10 ranking when we associated the answers very high importance and high importance. And we have a lot of items that were superior to the cutoff of 60%. The first one, to achieve complete withdrawal of daily oral corticosteroids with 91%. Equal percentage, 88%, for to have no asthma exacerbation requiring systemic corticosteroids and to reduce daily oral corticosteroids by at least half. In the third place, to decrease the number of asthma exacerbations requiring systemic corticosteroids by half with 86% of answers, and to have no side effects or to have minimal side effects were with equal percentage, 77%. And finally, to obtain an ACQ score inferior to 1.5 or an ACT score superior or equal to 20 points with 71% of participants. According to these results, we suggested the followed 4 criteria for evaluation of biological therapies efficacy in asthma at 4th month of treatment. The first criteria is to reduce daily oral corticosteroids dose by at least 50%, ideally to achieve complete withdrawal. The second criteria, to decrease the number of asthma exacerbations requiring systemic corticosteroids by at least half, ideally no asthma exacerbation after starting of biologics. The third criteria, to have no or minimal side effects. And the fourth criteria, to obtain asthma control, an ACQ score inferior to 1.5 or an ACT score superior or equal to 20 points. These criteria were validated by all the members of the expert panels, and we decided that the achievement of at least 3 criteria is necessary to conclude a good response to biological therapy. Of course, we can also suggest that if all the criteria are achieved, we have an optimal response to biological therapy at 4 months of treatment. Now we will discuss our results, and firstly, we can see that the specialists accord a very high importance to the reduction or withdrawal of daily oral corticosteroids use after starting biologics in asthma. It is an expected objective for all the physicians that prescribe biologics, because we know very well the adverse events occurred with prolonged use of high doses of systemic corticosteroids, osteoporosis, myopathy, diabetes mellitus, adrenal cortex suppression, lymphocyte cytopenia, immunosuppression, cataract, growth retard for children, sleep disturbance, mood disturbance, psychosis, Cushingoid appearance, abdomen striae, hirsutis, edema, neuropathy, hypertension, and dyslipidemia. We have now several fast steroid tapering schedule that was suggested to stop oral corticosteroids use after several weeks of treatment. But we know also that this quick algorithm to decrease and stop oral corticosteroids use is several times difficult to apply in practice, because in this study, the adrenal insufficiency occurred in 60% of patients. And we need to pay attention to the faster decrease of oral corticosteroids daily dose, and to evaluate systematically the hypothalamic pituitary adrenal axis when we have less than 5 milligrams per day prednisolone. We know also that biological therapies are effective to reduce oral corticosteroids use. And in this French-German study involving more than 300 patients, the omalizumab administered for 16 weeks reduces oral corticosteroid dose in 30% of patients, and 21% of patients stopped their oral corticosteroids use. Similarly, study with the mepolizumab showed after 24 weeks of treatment that the median percentage reduction was 50% in patients treated by mepolizumab compared versus 0% in the placebo group, and 33% of patients had a reduction of 90% to 100% in the oral corticosteroids dose after 24 weeks of treatment, and more than half of them a reduction by more than or equal 50% of the dose. Similar results were found by the benralizumab in these clinical trials involving 220 patients, the administration of the benralizumab for 24 weeks of treatment allowed to complete withdrawal of oral corticosteroids use after 24 weeks of treatment in more than half of patients treated by benralizumab versus placebo, and a reduction by at least half of oral corticosteroids use in 66% of patients. For dupilumab, clinical trial showed also that the administration of the dupilumab for the 24 weeks after 24 weeks of treatment allowed to change in the percentage in the oral corticosteroid dose by 74% in the group treated by dupilumab versus only 42% in the placebo group, and 48% of patients treated by dupilumab versus only 25% of placebo group discontinued oral corticosteroids use, while 80% in the group treated by dupilumab versus 50% in the placebo group had a dose reduction by more than half. The second point is that the participants, when they prescribe biotherapy, expect to reduce the number of asthma exacerbations for their patient, requiring systemic corticosteroids. And we know that the intermittent administration for at least 4 times per year of systemic corticosteroids, the equivalent of the dose by 1 gram, is associated with an increased risk for experiencing new adverse effects within the year, with an odds ratio at 1.3. We know also that the positive dose-response relationship exists with increasing risk of most adverse outcome when progressing from a cumulative systemic corticosteroid exposure of 0.5 to 1 gram to 2.5 gram, compared with people that have less than 0.5 gram. We know also that biological therapies are effective to reduce the number of exacerbations, and we can see in this meta-analysis involving more than 1,000 patients that the omalizumab administered for 16 weeks of treatment reduced the risk by 81%. And in this real-life study, Reality A, published the last year, we can see also that in real life, the mepolizumab reduced the risk of exacerbation by 71% in all the patients. And after 52 weeks of treatment, more than half of patients arrived to complete withdrawal of oral corticosteroids versus 7% before the inclusion in the study. The benralizumab is also able to reduce exacerbation risk by 49% compared with placebo at 24 weeks of treatment, and it was very well demonstrated by this clinical trial involving more than 400 patients treated by benralizumab, and compared to more than 200 patients included in the group placebo. Similarly, the administration of the dupilumab reduced the risk for asthma exacerbation by 48% at 24 weeks of treatment for both dose 200 milligram and 300 milligram. The third point to discuss is that the specialists prescribing biotherapy accord a high importance to the good tolerability of this treatment. And I think that the patient satisfaction is directly related to the good tolerability of the treatment, not also to the improvement of their symptom control and to decrease of the rate of exacerbation. The fourth point, the achievement of symptom control evaluated by validated questionnaires, ACQ or ACT, was considered more important by participants than the significant improvement of the score at 4 months of treatment compared to baseline. And we know that the omalizumab could decrease the ACQ score after 6 weeks of treatment by 1.14 in mean. The mepolizumab was able to decrease the ACQ score at 32 weeks of treatment by 0.94 versus placebo, and this result was significant. Similarly, the benralizumab was able to improve the ACQ score after 12 weeks of treatment, with a persistent result at 24 weeks of treatment. And also the dupilumab improved the ACQ score by a mean of 1.4 after 24 weeks of treatment compared to baseline. The improvement of the FEV1 was not considered a priority by the participants in our survey. Despite that, in the literature, we can find several data about the improvement of lung function by biological therapies. And you can see in this study, the mepolizumab could improve the FEV1 after 32 weeks of treatment by near 100 milliliter. The benralizumab improved the FEV1 by 150 milliliter after 12 weeks of treatment, and also the dupilumab improved the FEV1 after by 0.32 liter already after 16 weeks of treatment, with a persistent effect to 52 weeks of treatment. In conclusion, our survey identified the criteria considered as important by specialists for the assessment of the efficacy of biologics in severe asthma. Based on the result of this study, of this survey, 4 criteria were defined and are now ready for use as tools in routine clinical practice, but also in research studies. The ideal time of assessment of biologics remain, however, to be better defined, particularly in the context of partial responses, and this for each biologic. So more research is needed on optimal time and mean of assessment of these responses. Thank you very much for your attention.
Thank you very much, Angelica, for showing us the results of this survey that I believe is relevant because also in your topic, in your speech, you have emphasized that we have the belief and behavior of the specialist. We have the data coming from the clinical trial, and this means that we can compare and merge the results, and it is very interesting. I would like to make a couple of comments. First of all, the relevance of avoiding or reduction of OCS, that among the specialists is now considered the first criteria, is considered most relevant than improving control, for example, is more relevant than reducing the exacerbation. I believe that is the results of a great communication campaign about the side effect of the of these steroids, but also because we are sure that is available, is a goal that is achievable in real life. A significant lot of colleagues define that with this kind of biologics, we can reach oral corticosteroid 0, and we can reach again 0 exacerbation. This means that this is a results greater than that what has been shown in several trials, but this is the feeling coming from practice. And this is relevant for planning a new study. Another comment is about the safety, because among the criteria, after 4 months of treatment, the colleagues consider relevant to assess any kind of side effects related to the biological treatment. And we maybe the safety profile has not been so emphasized, because in real practice the side effects are really limited, but they consider always, they still consider that we have to watch properly our patients in order to avoid any kind of side effect. Last, the control, because it is relevant, and it is quite important, because we in several trials have been shown that we are able to improve several parameters, exacerbation, ACS, quality of life, and so on. But every time we are facing with a more global picture of the patient, as represented by control, and not all the trials are so positive in the sense, but the physician believe that at least the patient need to reach the level of control. We can ameliorate in the prosecution of the treatment, but they need to achieve at least the control. As mentioned at the beginning, is really an hot topic. We have a proposal. I would like to thank you for your effort, also because the paper is under evaluation, and we will spread through the all Indian asthma channel in order to raise the discussion, because we needed to start with some criteria, but obviously we are open, and we need to improve it, to change in the next year this criteria. Please, Angelica, a comment on this topic before a couple of questions that are arriving from the audience.
We have questions?
Yeah, the OCS reduction is the most relevant topic. At the second place, exacerbation. Do you believe that this is the future, is only a perception, or is related to the evidence? What is your feeling of this ranking?
I think that as most of physicians that prescribe biological therapy, for me the most important is oral corticosteroid withdrawal, because of all the adverse events, and of course the reduction of exacerbation is needed and related to the oral corticosteroid use, because we saw that for exacerbation we are able to have 1 gram per year, so it is already an important dose, and we can already have adverse events. So both are important, but for me it is most important the oral corticosteroid withdrawal.
Thank you, Angelica. One of our colleagues raised a critics to the survey, because the number of respondents was quite limited in terms of absolute number. And the question is how much generalizable we can consider these results. which is your opinion on this topic? We need to reach a huge number. Which kind of representative could be the sample? My personal opinion is that the survey are is not easy to power a survey in terms of target population that we need to collect, and the final results as not the results of the survey that is different by the proposal of the society is essential to bring the attention on the topic and to discuss. And a value of this sample is that all the people involved were prescriber. Is not a survey dedicated to all the physicians. This means that we are speaking with people deeply involved in daily practice, and every day they have to decide if they have to stop or to continue the treatment. This is a value, and again I repeat, the survey provides the material for a discussion inside the society. All the results are evaluated by different panel by the executive committee, and two different kind of publication can be generated by this kind of survey: a descriptive phenomenon. And this obviously, in this kind of publication, is emphasized the limit of the number of participants. The other kind of publication is a kind of manifesto, is a take-up position of the society based on the achieved evidence, but also on the available literature. And the document that the paper that Angelica wrote is the first one type, is a report of, and is a proposal for discussion, is not a statement.
And I would like to note that we done this survey in July and August, where a lot of people have holidays. And maybe this could explain the number of participants, but it have a strange, because the most than half of participants are people with experience in asthma, with age after 50 years old, 50 under 40 and 50 and 50 and 60 years old. These people are physicians with experience in asthma, and I think that their opinion is very important.
Thank you very much, Angelica. We are ready for closing this webinar. I would like to conclude this webinar thanking you obviously for your support also in the context of the INAS network, the Inter-Asthma Scientific Network, that is working on several topics. And I have obviously two proposals. First of all, I invite you to fill in a new questionnaire, a new survey that is available on the webpage of Inter-Asthma. The topic is triple therapy in asthma. Because we are facing with the launching of this kind of treatment worldwide. At the moment, we have collected 300 questionnaires from different countries, but we need to reach a greater number of surveys. And the second point is please provide us all your suggestions for a new survey, but more and more important is we need a new active member. If you want to chair it, to manage the survey, we will provide the scientific technological support for doing this, and we are sure that bringing our effort and sharing knowledge and tools we can collect in this moment perception, belief, behavior, and so on, but also this kind of information are relevant for a fruitful discussion, for a fruitful scientific discussion, for improving our practice. Thank you very much to everybody. See you at the next webinar.
Bye.
Bye.